Well, thanks again. Thanks for the introduction. Thanks for inviting me today to speak with your group. Yes, I'm very interested and excited about integrative medicine and the Osher Center. I am an associate professor in the department. I'm the PI of the Implementation Science and Engineering Lab, and we have several members of our group attending today. And yeah, excited that an opportunity came about. They were looking for a new leader to chair the Osher Collaborative Research Committee. And I said, well, why not? And I threw my hat in, and they said, okay. So as of January 2024, I'll be leading that research committee for the next year. So we'll see how that goes. I'm excited for the opportunity. And to learn more about integrative medicine and really to bring hopefully some of my background in systems engineering and implementation science, because I think there's a lot of opportunities for implementation research in the integrative medicine space. Having a little trouble advancing for some reason. Okay, there it went. So I'm going to talk about several projects today, two in particular. I'm actually up to 4 R01s at this point, so I'm keeping myself busy with NIH-funded research. The two I'll talk about today have a focus on digital health for alcohol use disorders, and they're both taking place. One is kind of finishing up, taking place at mHealth, and another one is going to be starting up with a population with alcohol-associated liver disease, also at mHealth and the University of Michigan. Also wanted to acknowledge my collaborator, Linda Park, who I think is here. She wrote a DFMCH small grant that was really instrumental in helping us get funding for the second R01 that I'll talk about, that we're really excited to get started on here in 2024. I do have a couple of disclosures to make. I have a shareholder interest in Chess Health, a small business that markets digital health applications to the addiction treatment field. And I also provide consulting on digital health implementation through the nonprofit NIATEX Foundation. So the work that I'm going to present today is really, I'm senior author on a lot of these papers and publications that we're going to talk about, but really Xiang Li, Changli Shi, Mingwan Ji, Linda Park, and Alice Pulvermacher have really been great collaborators to work with, and owe a lot of the credit for all the work I'm going to present today to them. And some of this work we presented recently at a conference in New York City, and all of these collaborators were there to present. So grateful to them for the work that they did to help prepare these the material that I'm going to share today. So just a little bit more about me. As Greta mentioned, I'm a systems engineer by background, so I got my PhD in health systems engineering from UW-Madison in 2012. And I think there's a lot of sort of misconception, or, just general not understanding about what engineering is really all about. But the best definition that I've heard came from, I was at a conference at the National Academy of Engineering, and the president said that engineering is really at its core about making science useful to people. And I do implementation research in healthcare, and I think that's really the exact same definition that I would use. We're trying to develop and implement interventions that are going to be ultimately helpful to people. And we know that a lot of research for various reasons never gets kind of translated into everyday clinical practice, and it's a very complex, really systems level kind of view that I take to try to maximize the probability that research is both effective and acceptable for individuals and used widely in the real world. So that's kind of the perspective that I bring as a systems engineer. So I'm gonna talk about kind of the history of our work around digital health and alcohol use disorders, and really kind of walk you through how things have evolved over time to where we are today. I've been doing digital health implementation research for probably at least 8 years, and the history that I or sort of the my origins come from a place that's been doing this ever since smartphones came out in 2007. I'm going to talk a little bit about the significance of alcohol use disorder and treatment accessibility. Um, I don't need to tell all of you, I think that alcohol use disorder is a really prevalent issue in the US and can be harmful. It's especially, Wisconsin has the highest rates of heavy drinking in the country. So it's particularly relevant to our patients at UW Health. And we think that mobile health or digital health interventions could potentially increase access to evidence-based treatments and prevention for alcohol use disorder. Pretty much everyone has a smartphone at this point, and there's some potential advantages to delivering prevention and treatment interventions via mobile technology. So I was at the College of Engineering before I came over to family medicine in 2017, and I got my PhD in 2012. I was working with the Comprehensive Health Enhancement Support System, the center that produced that technology. It's an mHealth app designed for AUD recovery. And I like to say that my mentor at Chess, Dave Gustafson, has been doing healthcare technology development going all the way back to the 70s and 80s. And so when the iPhone was announced in June of 2007, we put in our first NIH grant application to use smartphones for addiction treatment delivery in October of 2007, and we were one of the first research centers to get funded to do research in this area. So we've been at this since about as early on as possible with the advent of smartphones. So HS is sort of the first system that was developed. It's based on self-determination theory, and that self-determination theory basically posits that human beings have three basic needs. For competence, to feel master and control of their own lives and their environment, autonomy, need to be in control of their behaviors and goals. This is about choice and relatedness. People need to experience a sense of belonging and connection with other people and feel cared for by others, and be able to express care for others as well. So this, we've done a lot of thinking about how these concepts kind of interweave with the wellness model, the whole health model that's used by UW Health and now widely across the Veterans Administration and other places. But I think there's a lot of complementary aspects to self-determination theory and the whole health model. So HS was initially, this is what it looked like kind of in the earlier days. This is just on the left side, you have what it looks like for patients. The app on the screen provides, ability to kind of create a profile, discussion groups, information, the ability to answer self-monitoring surveys, and things of that nature. And then all of the data that's entered is available to clinicians via clinician report. So that, by clicking through a clinician, if they're monitoring a patient who's using the system, can learn more about, what's going on in the patient's lives. The original, I mentioned that, we wrote a grant right away. This system was tested in a randomized clinical trial with 349 individuals who were exiting 90-day residential treatment for alcohol use disorder. So these were people with severe alcohol use disorder who had already been abstinent for a period of time. And we did show significant reduction for patients using the HS app compared to the usual care group. So that study came out in 2014 in JAMA Psychiatry, one of the first published reports of a clinical trial studying digital health for substance use disorder. And we've kind of been building on that platform from there. I was interested in how to implement and scale this system, and looked at, writing a new grant that was funded by NIAAA to look at, how could we scale this up to UW Health and a primary healthcare system.
Andrew, I'm sorry
Yeah.
to interrupt, but your sound is going in and out a little bit. I'm not sure if it's your position or if there's a mic issue, but just goes out in and out a little bit. It might be helpful.
Okay, I'm going to try to go closer and see if that helps at all.
That's great. Thank you so much.
Okay. So anyway, so we were able to get a grant funded to look at how we could implement and scale the system in UW Health. We used a model. We knew that we would have to do some adaptation to the system to make it acceptable for a primary, sort of a primary prevention population. We use this system called the EPIS framework, that stands for exploration, preparation, implementation, and sustainment. There's kind of a lot there, but basically in exploration, we talk to stakeholders to understand the needs of the target population, select evidence-based practices, in this case HS, and then what types of adaptations need to be made. During the preparation phase, we look at barriers and facilitators of implementation and develop an implementation plan and implementation strategies. In our case, implementation, we ran a clinical trial where we recruited more than 500 individuals to use the system and studied its use. And now we're sort of in the phase of looking at what would it, is it worth sustaining this? What would it take to, what type of structures would need to be in place to keep this system like this going in this type of environment? So I won't, the methods were, pretty, not super hardcore. This was really about talking to people. I talked to several, of colleagues, some of whom I think are on the call here or on the Webex about, talking to primary care clinicians, clinic managers, behavioral health specialists, just to explain what we're trying to accomplish, and then basically learning as much as we could about the needs of the system and the patient population. Then during the preparation phase, we looked at the study design and what the implementation strategies should be to maximize the likelihood of uptake. We did usability tests with individuals who would be likely users of the system. And we wanted to look at different age brackets and different racial and ethnic backgrounds. So we come into an activity like this, we write a grant application, and we have certain kind of prior beliefs about what implementation should look like. And the best way to test kind of the validity of those plans is to talk to stakeholders and get feedback. So originally we thought that we would integrate data from the CHESS app into patients' electronic medical records. But we learned from talking to likely users, aren't really interested in having their care teams knowing about alcohol use. Primary care physicians aren't necessarily looking for more data to be monitoring with the information overload that's already happening. And, there's a lot of security and privacy issues with with adding new data to the electronic health record. So we ended up not doing that, and that was based on some engagement with stakeholders. We intended at first that we'd have like a clinic-based model where primary care physicians would be recommending the app to patients, and we talked to primary care physicians and behavioral health clinicians, and they sort of pointed us to the UW Health Center for Wellness, and we decided that we would use the health coaches working at the Center for Wellness within the healthcare system to provide support for use of the app. The original versions of HS were for people with severe alcohol use disorder, and for people with severe alcohol use disorder, it's really important that abstinence is the goal. We're expanding to a much wider population in primary healthcare system like UW Health. So while abstinence could be a goal of some of the individuals in our study, we also wanted to say that anyone interested in reducing alcohol use was a good candidate for this, so more of a harm reduction approach. Again, we had, along with the abstinence kind of concept, recovery model is really about doing everything possible to avoid alcohol at all costs, and really is kind of a disease oriented philosophy. So in our conversations with stakeholders at UW Health, we learned about the whole health model and how it forms the basis of our wellness orientation. And so we situated alcohol use in the context of the whole health model and how reducing alcohol use could improve wellness overall. And then sort of related to point two, we were going to be recruiting through just a couple of primary care clinics in the beginning, but in part because of COVID as well, we decided to go through the more of a healthcare system and community-based approach to identifying and recruiting patients to enroll in the study. So as a result, we adapted the app to hopefully be more acceptable to a broader population. Our conversations led to 3 new implementation strategies to support the use of mHealth. I'll just show them here. I'm going to get into more details about what those implementation strategies entail as we move forward. Anyway, so this is what you saw HS previously, and this is how we redesigned HS for this current study. We ended up renaming the app Tula, which is a Sanskrit word that means balance, and it's really centered and oriented around the whole health model and the circle of health. I think will be familiar to many of you on the Webex here. And really kind of put the alcohol related content under the food and drink aspect of the whole health model, but had it sort of permeate through all the different elements of the whole health model, but really kind of taking a positive orientation and situating alcohol use in that context. So we talked to we talked to 7 individuals. We developed sort of a prototype version of the Tula app. We talked to 7 individuals about, had them do this think aloud usability testing to verbalize thoughts on functionality design of the app. We then did some revisions based on that process, then did another round of near live usability testing with a different group of 5 participants, and really focused on assessing their perceptions of the acceptability of Tula. We learned through that process from community members that the overall language in the app needed to be simplified. We needed to understand how diverse interpretations of the same text could occur within different cultural contexts, and that various age groups had differences in technological literacy. So that led us to move away, really to move away from a lot of text-heavy content, to clarify some confusion around messaging, to lower the reading level of the text down to 5th grade, and to add frequently asked questions so that people could get help with using the app. So we adapted both the intervention HS and its implementation strategies through this exploration and preparation. Hopefully through the process identified stakeholder needs and concerns that could help us design strategies for successful implementation and sustainment in treating alcohol misuse within the primary healthcare system. So that was kind of the first stage of our study. We spent the first year talking to stakeholders, at UW Health and within the community, and that was in preparation for the clinical trial that actually tested the use of the system, and I'll go into the details of that now. Real quick, Greta, did my sound improve at all by moving closer to the mic? Seems like it's better.
Yeah, it's better. Thank you.
Okay, good. Okay, so I did want to offer a disclaimer that we have not published the results of this study yet. We're pretty much wrapping up data collection, but we're still still doing some follow-ups, and we're still working through some of the details of the analysis. We did publish a protocol paper that describes the design of this study in more detail. If you'd like to read about it, the citation is here. Again, this is a paper led by Dr. Park, who's a collaborator in our lab. So there's a literature out there on digital health implementation strategies. I guess this paper calls them behavioral intervention technologies, or BITs. On the left side of the spectrum, you're looking at human-delivered interventions, which really corresponds to traditional care within where you have a patient and a clinician, doing in-person treatment, and then you move to the right on the spectrum, and it kind of shows how you can have different levels of integration through digital health, where you look at an adjunctive bit as an intervention delivered by a provider with support from the technology, guided bits where the intervention is delivered by the technology with support from providers, and then fully automated bits where an intervention is delivered by the technology and there's typically no role for the provider. So I like to think of the left side of this as basically traditional primary care or any type of healthcare that doesn't use technology. And on the right side, fully automated bits would be like health apps that you download from the App Store that individuals use on their own. That there's really not a lot of overlap in the middle. Typically, care is provided basically in the traditional sense, or patients download an app and use the app in ways that are sort of independent of the healthcare system. So just wanted to lay that groundwork, which helped us design our implementation strategies. Our objectives in this study was to understand how varying levels of human interaction could affect the ways in which an mHealth system works. So we developed 3 different mHealth implementation support models. The first one is we call the self-monitoring group. So this is the group where patients or participants basically use the Tula app, downloaded it from the App Store and used it independently with really no involvement from anyone besides the participants themselves. We provided a little bit of technical support from the research team, but that was it. The second group received peer support from a community organization. So this is sort of a one-to-many communication model where individuals would have access to peer mentors who would be overseeing discussion groups and providing support to all the individuals who enrolled in the study. So we call that sort of a medium touch model, and that peer mentors can oversee, numerous individuals, and the nature of their communication is sort of, in a group setting. So maybe think of that as like a group visit type of format, although it's all done by the technology. And then we had a third group that was clinical support within the primary healthcare system, our high touch model that involved one-on-one health coaching. So we had what's called a hybrid type 2 implementation effectiveness study design to look at the effects of the 3 different implementation strategies on alcohol use and quality of life. We're also doing cost effectiveness analysis to understand what might be the optimal level of human touch required to implement mHealth. And our hypothesis was that different levels of interactions or sort of increasing levels of human touch would demonstrate increased effectiveness, and that we would then do cost effectiveness assessment to assess, sort of the best ways to disseminate digital health in the population. So I kind of mentioned this already, but this is just another illustration. The self-monitoring group had unguided use of the app. The peer-supported group had a community-based peer support specialist, an in-app discussion forum that was moderated by the peer support specialists. And then the clinically integrated group, each individual was assigned a health coach that would work one-on-one with the individual through up to 3, usually 30-minute health coaching sessions that were done over the phone. We planned on doing this potentially in person, but COVID made that impossible. And there was access to a discussion forum moderated by the health coach and a clinician dashboard for kind of looking at the activity of individuals within their use of the Tula system. In terms of inclusion criteria, had to be over or 21 or over, a desire to reduce alcohol use, had to own a smartphone. We didn't provide phones for this study. Individuals had to live within the geographic area that serves UW Health. So we would, check IP addresses to make sure that they're coming from zip codes that were within the UW Health catchment area. And individuals had to meet the criteria for mild to moderate use of alcohol. And some sort of, there's a lot of technical details around that, but we had a cutoff using the audit score, where if they answered, I think, 6 or more questions, yes, for a diagnosis of severe alcohol use disorder, we thought that those individuals would need more support than just using an app. So we had excluded people with the potential for severe alcohol use disorder. So this is really more of a, looking at people who are like, feel like they're drinking more than they want to, but are not in, kind of severe territory. So a little bit more of a prevention orientation than a treatment orientation. So this is the consort diagram showing our assessment for eligibility. We We assessed almost 2,300 individuals, ended up randomizing 558, and then assigned them in equal proportion to each of the three groups that I mentioned earlier. One thing worth checking out on this slide, if you look on the right side, our follow-up rates, 93% at 3 months, 84 at 6 months, 72 and 67 at 12 months. For a digital health study, there's our really quite exceptionally high follow-up rates. If you look at comparisons to a lot of the literature. One thing worth noting, though, is that in the clinically integrated group, you can kind of see that 55% followed up at 12 months, quite a bit lower than the other two groups at 71% and 75%. And this is something that we'll talk about more, and we're trying to understand better, because we did see more people drop out in the clinically integrated group that received one-on-one health coaching. Our primary outcomes were percentage of risky drinking days in the last 7 days. So basically, that's defined as 4 or more drinks for a female, or 5 or more drinks for a male. So you just take a look at that, out of the last 7 days, follow back how many did you drink more than 4 or 5, and then just calculate a percentage based on that. And we looked at quality of life using the PROMIS global health, physical and mental health scales. Some details on the analysis plan. It was a general linear mixed model with repeated measures from month 3 to month 12. I won't go into all the details of this. Again, if you'd like to, this is listed in the protocol paper. We controlled for baseline levels of outcomes at baseline, and design factors like gender and severity. So just a quick look at the study populations. If you look at overall, 66% female, 64% had mild alcohol use disorders. That leaves the other 36 with moderate. Largely white population, 5% Black, 3% Hispanic, and also a pretty highly educated population, which is typical of the Madison community and the UW Health catchment area, and 67% were currently married. In terms of the percentage of risky drinking days at baseline, overall it was around 38% at baseline, and then the quality of life and mental health measures are listed there. I think they probably make more sense if you look at them in terms of changes over time, since those measures aren't too informative. But in terms of the percentage of risky drinking days, 38%, be looking at roughly 3 days out of 7 per week across all the groups. So these were the results that we found in terms of risky drinking days. So what you'll see here, the 3 different groups are listed. There was a significant reduction in alcohol use across all of the groups. So basically, you have reductions from around 40% to around 25% between month 0 and month 3, and then further changes after that. The clinically integrated group showed reduced risky drinking days from month 3 to month 12. When you look at changes, differences between the groups, we didn't find any statistically significant differences between the groups in terms of their effect on alcohol use, but they all improved alcohol use significantly. Mean physical health. So this gets to physical health symptoms. We didn't find any group time or group times time interaction effect on physical health. But we did show improvements on mental health. Both, for all the groups showed improvements in mental health, and the health coaching group showed improved mental health compared to the self-monitoring group. So it appears that health coaching had a positive effect on mental health. And I should note also that the peer-supported group showed improved mental health from month 3 to month 6. So some difference in groups between mental health from the baseline to the 12-month mark. So just to briefly summarize, the group showed lower drinking days over time, but no significant difference between groups. The clinically integrated or health coaching group had lower risky drinking days at month 12 compared to month 3. The clinically integrated group showed improved mental health compared to the self-monitoring group across the study period, and the peer-supported intervention improved participants' mental health from month 3 to month 6. We didn't see any effect on physical well-being as part of this study. So right now we're trying to kind of sort through the implications of these findings, and our preliminary thoughts. Something hopefully everyone can kind of think about. It might make sense to offer the self-guided version of the app to everyone, because all 3 groups improved their alcohol use significantly. This did take place during the context of COVID, where alcohol use rates, we know, went up across the United States and across Wisconsin. We think that, to jump below, that there's research showing that patient choice is really essential for acceptability and autonomy, that it might make sense to provide the option for health coaching due to potential improvements in both mental health and alcohol use. And that connecting patients with peer support may also improve patients' mental health. So that's kind of where we're at right now. We'd love to, continue engagement with this group and other stakeholders from UW Health to kind of see how this might, whether and how this might be sustained and scaled within the health system, and how to do it. In terms of limitations, this is a pragmatic trial. We didn't have a pure control group. Doing that, the FDA requires a sham device that basically doesn't do anything, and that didn't seem to be practical, and that was something, talking to stakeholders, didn't seem like would be feasible to do in this type of a study. The alcohol use is self-reported, so there's some limitations associated with that. We did all of the coaching and peer mentoring remotely due to COVID. And again, our population, mostly white, female, and fairly highly educated. So some questions about generalizing the results to other populations. So we're actively trying to, we're doing some qualitative analysis, talking to the peer mentors and health coaches and individuals who received peer coaching and or peer mentorship and health coaching to understand their experience. And we're learning a lot through that process. We're doing economic analysis to study, what would be the cost implications of scaling this at a larger scale. Looking at a number of secondary outcomes. I just focused on the primary outcomes of risky drinking and quality of life. And then we're going to be doing mediation analyses to try to understand it, kind of how the constructs of self-determination theory might operate to have effects in this population. So I guess I'll cover the last presentation here and then leave time for questions. We are getting ready to publish the results of that study. we are now looking at starting up a new project with patients with alcohol-associated liver disease. And I'm going to report the results of a pilot test that was led by my associate, Dr. Linda Park, through a small grant from DFMCH. Again, we have a publication out led by Dr. Park on results of this usability test for patients with alcohol-associated liver disease. So again, we're now, kind of going back to the original population. We looked at scaling HS into prevention for a broader population. We're now looking again at individuals with alcohol-associated liver disease. So, almost by definition, kind of on the severe end of the spectrum, have already experienced some negative health consequences due to alcohol use. We're seeing, at a population level that just rising rates of alcohol use are increasing the burden of alcohol-associated liver disease, especially in women moving forward. In contrast to the harm reduction model, for people with liver damage, alcohol abstinence is the only intervention that can help reduce morbidity and mortality. But one of the things that's, a big gap in ALD patient care is that there's just not a lot of available AUD treatment, and it's not well integrated into the healthcare system. So we're kind of looking at that gap with this project. So we know there are effective treatments for alcohol use disorder that can be recommended: motivational therapy, cognitive behavioral therapy, motivational interviewing, pharmacotherapy, digital interventions that I just talked about. However, this is starting to change a little bit at UW and at Michigan, but by and large, the most common, when an individual comes in with alcohol-associated liver disease, the recommendation is basically you need to go to AA and stop drinking and, come back in 6 months, especially for people who are, getting close to a liver transplant. A lot of it is really up to the individual, and there's not a lot of support from the healthcare system. So we're kind of trying to change that model of care and more actively support treatment of alcohol use disorders for this population who's really in pretty bad shape as a result of alcohol use. So some of the barriers to treatment for alcohol use disorder for patients with ALD: geographic distance. Often you're referred, from far outlying communities to come to UW Health for this type of treatment. And the morbidity can compromise the ability to travel. There's some issues with pharmacotherapy around liver metabolism and toxicity, and just overall kind of lack of comfort and education how to safely prescribe medications to those with advanced liver disease. And really, there's been a separation of hepatology and addiction medicine or addiction treatment in practice. So we're kind of zeroing in on that gap and hopefully trying to create some interventions that can be helpful. So we did a pilot study to assess the feasibility of ALD patients using, we actually had them use the Tula app because that's what we had developed and ready for use. We wanted to understand how patients would use and perceive the app and its usability. And this, over the long term, is, we're kind of looking to potentially establish a new standard of care for patients with alcohol-associated liver disease. And study the role of clinicians in the healthcare system and helping to provide access to those types of treatments. So we did a mixed methods usability test with purposive sampling in the hepatology clinic. We did an initial pre and post semi-structured interviews. We had individuals download the tool app and use it for 30 days. And we provided incentives of up to $100 to use the app and to provide or to do the interviews and provide survey results for us to assess the preliminary effectiveness of the app. So for this one, inclusion criteria was 18 years or older, had to have a diagnosis of both ALD and AUD, alcohol use in the last 6 months, owning a smartphone, can read and write in English. For exclusion, if people already needed a liver transplant, we excluded them from this study, this usability study, and severe cognitive impairment or severe mental illness. So we were able to recruit in a fairly short period of time. A lot of this was really to see how feasible it would be to recruit individuals with ALD. We recruited 11 participants, 5 males and 6 females. Again, small sample, but basically 9 white individuals, 1 Asian and 1 mixed Hispanic Irish, age range 33 to 62. The range of ALD diagnosis was pretty significant, from 3 weeks to 20 years, most were within the last 3 years. And 1 of the 11 had some prior mHealth use for alcohol cessation. So we did a mixed method analysis, pretty basic, just kind of descriptive analysis of how patients or individuals use chess. We looked at the time, just clicks and time spent on each page. And we did qualitative interviews that were analyzed using thematic analysis. And we used a software called Deduce to analyze the qualitative data that was collected. So quantitatively, individuals spent an average of a little over half an hour using the app on the first day. And over the next 30 days, engaged an average of 17 days and 209 total page views, 40 minutes in the app total. Pretty high levels of use for digital health. On any given day, 55% of the patients were active. All of the weekly engagement rates, everyone signed in at least once per week, and all patients completed their 4 weekly surveys distributed through the app. So we kind of showed through this that the app was usable, and we could recruit individuals, and we could get them to respond to surveys for primary data analysis. We identified three themes through the qualitative analysis. The first one, participant experience with ALD diagnosis. So we heard things like this is a serious wake-up call, information overload upon diagnosis was a concern, and feeling that there wasn't a lot of support for individuals after a diagnosis. People are swimming alone with this serious health diagnosis. Some of the potential benefits that were mentioned, weekly surveys and tracking features. This is something that we've kind of heard a lot, just to reflect on and report alcohol use can cause some reflection and might be an intervention in itself to just think about, do I need to use alcohol? Identify urges and triggers. Motivational quotes could be inspiring and help people think of different ways to maintain my outlook in health. That individuals, by and large, thought that the app was easy to use, didn't require a lot of technical sophistication. We also wanted to know from participants, if we're going to, for people with alcohol-associated liver disease, what types of information would be needed. And so people wanted to know more about ALD. This is not something that we've really incorporated into any prior versions of the app, but we got a lot of information about what we need to include for this upcoming study. Support to improve liver health, including nutrition. That's not something that is readily available out there, so providing some guidance around that. And then people did, express a lot of desire for an option for a peer-to-peer discussion forum, especially because we've heard this across a lot of our studies, that people find it hard and potentially uncomfortable to go to in-person AA meetings. And so having sort of an anonymized and virtual peer discussion forum could be helpful. So overall, participants found the app easy to use and potentially useful in helping with alcohol cessation. They appreciated curated information and resources that were organized in categories, and just sort of the ability to go through and read about any topic they were interested in. Certain features of the app played a key role in keeping participants engaged. So we, I won't go into details of that, but we looked at sort of their engagement with different elements of the app. And I think the tracking feature is one that is, kind of both of these studies are showing is an important element of these digital health interventions. I know I'm running out of time, so I'm going to skip through this one kind of quickly. I think I've managed to mention a lot of this. Again, we're now trying to figure out how to integrate the whole health model with self-determination theory within, and developing this new version of the app. We have done it with the Tula app, and we're sort of amalgamating the HS app, which is abstinence focused, with the Tula model, which is sort of more wellness focused. We're in the process of working with the software vendor to go through that process, but we've had a great experience with the whole health model and want to retain a lot of the elements of it. Skip this one as well, so I can leave time for questions. But I did want to mention that these pilot data were really helpful for us. We had a revise and a resubmission for an R01 that scored well, able to show this feasibility data, and it helped us, I think, move into the fundable range. So we, as of December 1, have a new R01 to test this app in a RCT with 300 participants with ALD at UW Health and the University of Michigan. So we're excited to get that going. I did want to mention too, I talked about digital health and alcohol today, but I'm also very interested in chronic pain. We do research in that area as well. I think there's a lot of opportunities to test implementation of evidence-based interventions for chronic pain in lieu of opioid prescribing. And I'd love to hear your thoughts on this topic. And with that, I will close and hopefully leave time for suggestions, questions, and comments. And thank you. I think I just got done 1 minute late.
Thank you so much, Andrew. Fascinating and exciting, and the gears in my brain are turning. I'm wondering if folks have questions, you can either put them in the chat or raise your hand. I'm a little curious about, I'll start off with my question with what did the app how did it move through like a whole health model, or how did that actually look for the user? Can you describe it a little bit?
Yeah. So in the Tula study, the home screen of the app is the circle of health. Mm-hmm. And so that was how we kind of introduced it. And it was, individuals had more or less kind of self-guided use of the app. They could sort of click into any element of the circle of health and read content and get pointed to different types of features that supported the different elements of the circle of health. That like the health coaching group in particular, which had more of a more highly kind of mediated and guided approach to using the app. I think they actually started with the question of what matters to me, and that was embedded in the app itself, and there were modules for goal setting. Although I think that we're going to have to do more in-depth kind of analysis of how individuals use the app. It was a pretty free-ranging, though. It wasn't very regimented. If I had to describe it, I think the health coaching guidance would make it a little bit more regimented, and I know that they had an approach that was kind of outlined. The peer coach or the peer mentors did something similar in terms of their introduction of the app, although I don't think they were quite as oriented around the whole health model. So yeah, it's kind of a tough question. We're going to have to look into the actual patterns of use. We're kind of focused first and foremost on the intention to treat analysis and our effect on the primary outcomes. But we'll be looking into that in more depth.
Thank you. Amy?
Good
Since
morning.
you had a question?
Yes, good morning, Dr. Quanbeck. Thank you so much for researching in this important area and for being interested in chronic pain. I am both an integrative medicine specialist and an addiction specialist, so our intersections cross quite a lot. First of all, do you know of any apps that a clinician can use already that have been vetted and are available for use? Because your app, you have to be from those research centers already. Are there any other apps that you recommend that people use already?
In terms of for alcohol use or for addiction in particular?
Yes.
Yeah, that's an interesting question. There was a company called Pear Therapeutics, which was the first company to get FDA approval for providing addiction treatment, and the app had to be prescribed by a physician, and that was big news. Unfortunately, that company went bankrupt in pretty short order, and that is something that I was involved with some of the earlier versions of implementing that app. And we're trying to understand what went wrong in the implementation model. So the one that was FDA approved is no longer available. I don't know if there's any companies that are going to be buying up the intellectual property that would make that available again to individuals. Right now, there's not a lot out there. I think that there's a company called Dynamicare, which is still doing some good work. The company that I've been involved with, called Chess Health, is providing access to apps. However, they are like a business to business, so they don't, it's not something that can be downloaded individually. If you're an individual, you have to work through the company, through the healthcare organization. And so there are some self-help apps out there. I should know more about them than I do. I could probably look into that and follow up. They're not coming, the names of the apps are not coming to me off the top of my head. I think it does show that there's still a lot of difficulty in terms of how do we integrate these types of digital health apps into clinical practice, and that's kind of why we're doing research on it. But certainly there are some apps available through the App Store that certainly could be helpful for people. I think the thing is, almost none of them have a lot of like clinical trial evidence, and so it's hard to recommend them with a ton of confidence. And I, as a research person, I'm a little bit biased towards the evidence-based apps, but certainly I think there's probably no harm in a lot of the self-help apps that are out there, and we can look into that. I'll ask my collaborators who are here on the call to help make note that we should look into that and provide some recommendations.
Thank you so much. Keep up the great work.
Thanks. Vinny, you had a question, and then we'll go to Shelley after Vinny.
And thank you so much, Andrew, for this work. Really appreciate hearing about it. One question for you. I was just curious, to what extent do you feel that the whole health component of the intervention played an active role in supporting people versus just having an app available?
Yeah, another good question. It's a little bit difficult to untangle the differences. I mean, I think we are doing qualitative interviews with individuals right now, and one of the things that we have been hearing is that I think having the ability to track and then get sort of self-feedback and just to look at, here's my, probably similar to, how a Fitbit works in terms of like, keeping track of your goals for getting steps in this case, and then looking at monitoring progress and getting some positive feedback from the technology about, positive changes that individuals are making. It's difficult for us so that's kind of what we're hearing qualitatively. I think we have ways that we can look quantitatively at the actual ways that the app was used, to sort of, look at was the actual use of the app directed towards elements of the whole health model, but we haven't been able to look into that in a lot of depth yet. So I'm afraid I don't have a great answer to your question at this point, but I think it's something that we're going to continue looking into.
And I'm going to ask maybe Sarah I'm going to read one more question from Shelley Shaw, but as you answer that, Andrew, I'm going to ask Sarah to put up the CME slide so folks that want CME for this presentation can get it. Andrew, Shelley asks, she's number one, thanks for sharing this great work with us. I'm curious about the next steps in understanding generalizability, particularly wondering about strategies you're considering to increase racial diversity in study population. If you thought about partnering with public health who might be interested, as substance use prevention often aligns with community health assessment priorities.
Yeah, no, I think that's a great suggestion. We made a lot of efforts to more broadly engage with the community. When we looked at the UW Health population, it just is, tends to. So we looked at a couple of things. Our population was pretty similar to the overall population of UW Health, although it was, again, a little bit more highly educated and white and female. And there is research out there that, this type of research tends to be when you have a volunteer kind of basis. That's the type of that's the kind of mix of population that tends to be represented. But I think, and Linda Park, who was on the Webex today, did a lot of, made a lot of efforts to do a community outreach. I think a lot of it was also difficult because of, COVID and just not easy to get out there in the community. But I think that going forward is something we definitely want to prioritize, and we are prioritizing in a lot of different ways. I do want to point out one thing is that we did a prior study of HS, the second kind of replication, and that was done in Philadelphia with a population that was primarily African American and male. And so we have shown that this does work in a very different population. But it's hard to generalize too much when you're looking at every population is different. Here we had sort of a mild to moderate alcohol use disorder. The one in Philadelphia was people with severe alcohol use disorder. So it's never, there's always a lot of caution that has to come with generalizing from any study to other populations. So I think it's just going to require more community outreach and engagement, and Linda and I are both committed to doing that.